Hey everyone, I hope you all are doing fantastic. I am Akshay Kumar and I welcome you all to the channel Sedative Physio English. Here in this lecture, we are going to discuss about the physiotherapy assessment and the physiotherapy management of the Parkinson's disease. But these two steps will take a longer duration, these two steps will take a longer time. So here in this video, we will mainly focus on the physiotherapy assessment of the Parkinson's disease, and in the upcoming next lecture we will discuss about the physiotherapy management and the treatment protocol of the Parkinson disease. Okay, and if you want the notes or slides of this topic, you can simply DM me on the Instagram, or you can message me on the WhatsApp too. There is no big deal with it. Okay, so let's start our today's topic, physiotherapy assessment. This management is the part of next lecture. Here we are not gonna discuss about management because it will be around a video of 1 hour and you will also lose the interest watching such a long video. So here we will discuss about the physiotherapy assessment. Okay, now without wasting the time, let's start our topic, assessment for the Parkinson. See, first of all, this Parkinson is a neurological condition and a proper assessment is very important, whether it is the case of any neurological condition, whether it is the case of any orthopedic or a gynec condition or any pediatric condition. In any department, in any condition, a proper assessment is very important. Okay, and there are some points that are very common in all these assessments. Like, first of all, we have to go for the demographic data. Okay, first of all, we have to go for the demographic data. In the demographic data, we have to ask for the name of the patient. First of all, there will be date mentioned on the top of the prescription paper, on the assessment paper, on the date on which you are taking the assessment of the patient. Okay, in the demographic data, you have to ask for the name of the patient, the age of the patient, the sex or the gender of the patient, the address of the patient, and the occupation of the patient. Now, why these all stuffs are very important? First of all, age and sex is very important because there are many conditions in the neurological case or any orthopedic case that are age and gender specific. For example, here we are discussing about the Parkinson. Parkinson itself is a age related disorder. It is related to age. How? Parkinson's disease is mainly seen in the patients with age of 55 or higher, 55 or higher. That's why Parkinson's disease is a age specific disorder, so we can conclude it. Now, why sex is very important? Again, there are many disorders that are gender specific. For example, in orthopedics there is a condition called osteoarthritis. I think you all know it. So, osteoarthritis is a gender specific disorder. It is mainly seen in the females. Females are more prone to osteoarthritis. So, in this way, we can conclude many things on the basis of the age and gender. Now, address and occupation, why these 2 points are very important? So, with address and occupation, we can get to know about the daily lifestyle and the surrounding of the patient, in which surrounding the patients work, in which surrounding the patients live. Surrounding and the occupational environment makes a great impact on the person health and its biomechanics. Okay, now after the demographic data, we have to go for the chief complaint of the patient. Second point is chief complaint. Now, what is chief complaint and why it is again important? So, chief complaint is something that patient tells you about his or her problem. The patient visits you, the patient visits your clinic, and he or she elaborates about the current condition of his or her body. Okay, you have to write the chief complaint in exact the patient's language. You don't have to add any technical word or any medical related terminology in the chief complaint. You have to just simply write the chief complaint as the patient says it. Okay, now after the chief complaint, we have to go for the history. Now, history is very important in the assessment. Why? Because history of the any medical history can influence the present treatment protocol, and if you get to know about the history of the patient properly, you can also design a good treatment protocol. The chances of the recovery of your patients will be much more higher. That's why history is very important. Now, inside the history, first of all, there are different types of history. First of all, we have to go for the present history. Present history. In the present history, we have to ask for the onset of the current condition, whether the onset was sudden or the onset was gradual, it progressed gradually. Okay, so we have to check for the onset of the current condition and any associated problems with the current condition. Okay, we have to ask for these 2 points. After present history, we have to go for the past history. In the past history, we have to ask the patient for any past medical condition, whether it is hypertension, whether it is diabetes mellitus, or hyperthyroidism, hypothyroidism, or any medical condition. Apart from this medical condition, we can also ask the patient for any road traffic accident or any trauma, etc. Now, if the patient was having any of these conditions, then the patient must be taking some drugs. Then we have to ask for the drugs that was patient taking for. Okay. Now, after the past history, we have to ask for surgical history. We have to ask for any surgeries in the past. If there is any surgeries in the past, then we have to ask the patient for the location and it was the which type of surgery, whether it is any repairing surgery or there was a removal of any organ or the part, etc. We have to ask for the surgical history. Then we have to ask for the history of any smoking, alcoholism, or any drug abuse. Okay, this is also very important in the history of the patient, because it also influences the present condition. It also makes a great influence on the present treatment protocol. That's why the smoking or alcoholism or any type of that's why the alcoholism, the smoking, or any type of drug abuse history is very important in the case of any neurological condition, orthopedic condition, or in any condition. Okay, so after the history, we have to go for the observation. Okay, so we have to go for the observation of the patient. We have to observe the patient. What are the things that are visible in the patient's body? Okay, so first of all, we have to check for the general condition of the patient. By observing the patient, you can conclude what is the general condition of the patient, whether it is good, whether it is fair, whether it is poor. You have to classify between these three. Now, second is the patient's behavior and the patient's level of awareness. These 2 points are very important. Why? Because patient's behavior and patient's level of awareness also makes a great influence in the recovery process and in the treatment protocol, because an active participation of the patient in their whole treatment protocol, in the whole treatment regime, is very important for the proper and the fast recovery of the patient. So we have to check for the active participation of the patient, whether the patient is cooperative or uncooperative, whether the patient understands what you are saying to him or her or not, whether it is conscious or not. We have to check for the level of awareness. Okay, now posture. In the case of Parkinson, there is a postural abnormality. Generally, the patients with Parkinson bends his or her upper trunk. The upper trunk is in the forward flexed position, and this leads to many different complications in the pulmonary area. Okay, so we have to assess further, we have to observe for the posture of the patient. Then any injury, is there any injury visible on the patient's body or not? We have to check for the skin. On skin, we can check for the skin discoloration. Is there any bruising on the skin? Is there any cyanosis present on the skin? Okay, so after the skin, we have to check for the gait pattern. The gait pattern is highly affected in the patients of Parkinson. Generally, in the Parkinson, we can see the festinant gait, the freezing of gait, or the shuffling gait. Okay, so gait pattern is totally affected in the case of Parkinson. That's why we have to assess for the gait pattern. We have to check for each and every analysis. But here in the observation section, we will only observe the gait of the patient. We will examine in the examination section. Now, tremor. Tremor is one of the characteristic feature of the patient of Parkinson. So we have to check for the tremor. Now in the tremor, we have to check for the intensity of the tremor. We have to check for the location of the tremor. We have to check for is the tremor is in resting state, or is the tremor develops by doing any specific job or any specific task. So we have to check for the tremor. And one important thing is the tremor present bilaterally or unilaterally, or it is specified to any one limb. Okay, so we have to check for all these. Now, any deformity. Generally, the kyphosis is seen in the patients of Parkinson because of the forward bending of the upper trunk, that we have also discussed in the posture section, that the patients of Parkinson keeps their upper trunk forward bended, forward flexed. So due to this posture, the deformity develops in the patient of Parkinson, and we have to check for it. Okay. Now, after the observation, we have to go for the examination. Now we will examine the patient. In the examination section, we have to go for the GCS. Now this GCS is also related with the level of awareness that we have discussed in the previous slide. GCS, through the GCS, we can conclude the level of consciousness of the patient. Now, memory, speech examination, memory and speech examination. These two examinations we will discuss in the upcoming slide today. Here, just skip these two. We will discuss it later. Okay, now in the sensory examination we will have to check for the superficial, the deep and the combined cortical sensations. These three important sensations are to be checked in the patients of Parkinson. For the superficial examination we can go for the pain, the touch and the temperature. In the touch we can go for the fine touch as well as the crude touch. In the temperature we will go for the hot and cold temperature, is whether the patient can identify, can recognize the temperature or not. Now in the deep we have to go for the pressure, vibration and the joint sense. These three sensations are to be checked in the case of deep sensory examination. Now in the cortical, in the combined cortical sensation we have to go for the tactile localization, the stereognosis, two-point discrimination and double simultaneous stimulation. Now let's discuss some points that are something difficult to understand. First of all, what is joint position sense? We are taking an example. Just imagine there is a patient sitting in front of you all. First of all, you have to close the eyes of the patient. Then passively in the right hand of the patient you will flex the elbow of the right hand of the patient at 90 degree. Okay, passively. This is done by you on the patient's body. The patient's eyes is closed. Now you will ask the patient to attain the same elbow position in the left hand without watching, without seeing the right one. Okay, so if the patient is able to do the movement, if the patient is able to attaining the same position without visualizing the movement, then the joint position sense is absolutely fine, there is no issue with it. But if the patient fails to do so, then there is something abnormal with the joint position sense. Now let's come to the combined cortical sensation. Here in the tactile localization we will close the eyes of the patient again and we will touch on the skin of the patient, and then we will ask for the location of the touch. If the patient is able to identify and describe the location of the touch, then the combined cortical sensation is very fine, there is no issue with it. If it fails to do so, then there is issue with the combined cortical sensation, especially tactile localization. Now in the stereognosis, what is stereognosis? Here in this examination we will close the eyes of the patient and we will give some familiar object in the hand of the patient. The patient touches the object and feels the object through his fingers, through his hand. Here the patient's eyes is closed, here you have to keep it in mind. Okay, the person feels the particular object with his or her hand, with his or her fingers, and the person tries to recognize and identify the object without seeing it, without staring at the object. If the patient is able to identify the particular object, the stereognosis is absolutely normal, there is no issue with it. Okay, now after the combined cortical sensations, we have to check for the cognitive function. In the previous slide, I just told you that we will discuss about the memory and speech later. So here it comes, the memory and speech. In the cognitive function, we have to check for the memory, the orientation of the patient, the conceptual reasoning and the judgment of the patient. With these four, we will also check the speech of the patient, and memory it is mentioned here. These all stuffs are checked through a scaling system, a examination called mini mental status examination, MMSE. What is MMSE? It is a set of 11 questions that is used to check for the level of cognitive function in the patient. It includes thinking, communication, understanding, memory, speech, writing. These all stuffs are included in the MMSE, mini mental status examination. Now, what is mini mental status examination? What are the questions that are asked in the MMSE? So, in the MMSE, first of all, we have to ask the patient for the time, today's time, what is the time, which day is today, what is the date, month and year. We will ask these 5 questions, and on the basis of these 5 questions we have 5 marks here. If the patient is able to tell all these stuffs correctly, we will give the 5 marks to the patient. If it fails, then for example, if the patient is able to tell you only time and day, then we will give 2 marks. Okay, now here after these things we will ask for the place, the floor on which the patient is sitting, the city of the patient, the state and the country of the patient, and again we have 5 marks for each. Then you have to name 3 objects, any random 3 objects like cat, bat, ball. Okay, for example, cat, bat, ball, and you will ask the patient to repeat these 3 words, that is spoken by you. Okay, so if the patient is able to repeat those 3 words, we have 3 marks here, 1 carrying each. Okay, now we have to go for the serial subtraction like 100 minus 7. We have to ask the patient to do a subtraction like 100 minus 7, it is 93, minus 7 again. Okay, so we have to do these things up to a level of 5, and again it carries 5 marks, 1 carries each. Then recall 3 objects named above. See here in the section 3, you named three objects and asked the patient to repeat these three objects. Now you have to ask the patient to recall these three objects again in the section 5. If the patient is able to recall these three objects, the marks will be 3, it is normal. And this assessment is for the memory, for the short-term memory of the patient. Now in the sixth section, you will ask the patient to name two words. In the third section, it was you who has spoken three words, but here in the sixth section, the patient will name two words, any random two words. Okay, now follow 3-step command. You will give a 3-step auditory command to the patient, and patient will follow the same. If the patient is able to follow, it is absolutely fine. If the patient fails to do so, there is something error in the patient. Okay, now copy intersecting pentagons. Okay, you have to make two pentagons intersecting each other, like 1 2 3 4 and 5. This is a pentagon. Again 1 2 3 4 5. This is again a pentagon. Okay, and now these two pentagons are intersecting each other. You will just make a diagram like this and ask the patient to repeat this diagram, to copy this diagram. Okay, if the patient copies it successfully, there is a fantastic job, there is nothing error. And if the patient fails to do so, there is something unusual with the patient. Now here in the 9th section, repeat therapist line. You have to speak a whole sentence in the front of the patient, and the patient will repeat the same sentence as told by you. Okay, now follow the written command. You have to write a command on a paper and you will give the patient will read the command and perform the particular command. Now at last the patient will write a random sentence, any random sentence. Okay, so these all stuffs, these all examinations are under the mini mental status examination, and on the basis of the performance of the patient, we will give the marking to the patient and we will check for the cognitive level of the patient. Here in this mini mental status examination, we can see that we have checked the memory of the patient, we have checked for the speech of the patient, we have checked for the judgment level of the patient. Okay, so these all stuffs can be examined through the mini mental status examination. After this MMSE, we have to check for the postural control and the balance. Here in the case of Parkinson, the postural control and balance is totally affected. How? See, the patients of Parkinson have a postural deformity. I have already discussed it earlier. The patient of the Parkinson keeps his or her upper trunk forward flexed, and due to this forward flexion of the upper trunk, the center of gravity shifts upward, and if the center of gravity shifts upward, then there will be loss of proper balance in the person. Okay, so that's why the postural control and the balance is totally diminished, it is totally affected in the case of Parkinson. So we have to check for the postural control, especially the balance, and the balance is assessed through the Burge balance scale. Now again, this is something new. What is Burge balance scale? It is simply a set of 14 activities that are used to examine the postural control and the balance of the patient. In this scaling system, in this examination, each activity carries 5 points ranging from 0 to 4. We will ask the patient to do the activity, and on the basis of the quality and the experience of the activity, we will give the marking to the patient from 0 to 4. Okay. Now, what are the activities that are included inside the Burge balance scale? So, it includes these all activities like sitting to standing, standing unsupported, sitting unsupported, standing to sitting, transfers. Okay, so we will ask the patient to do these activities one by one, and on the basis of the performance of the patient, we will give the marking from 0 to 4, whether it is 0, 1, 2, 3 or 4. 4 means it is totally normal, 0 means it is totally affected, and between this 0 and 4 depends on the performance of the patient. Through this scaling system, we can check for the balance of the patient. This Burge balance scale is also used in the case of stroke. In the patients of hemiplegia, we can also check for the balance through this Burge balance scale. Now, after this balance and postural control, we can go for the chest assessment. Now, chest assessment is very important. Why? Because of the forward bending of the upper trunk, there is a kyphosis deformity seen in the patient of Parkinson, and due to which the lungs collapse. The lungs gets affected due to the postural instability of the upper trunk, and the breathing pattern also gets affected. So we can check for the breathing pattern of the patient, the inspiratory to expiratory ratio, and the chest wall mobility. This is very decreased in the case of Parkinson. Okay, in the case of Parkinson, chest wall mobility, chest wall expansion is very diminished, it is very decreased. And you all know, if there is less chest wall mobility, if there is less chest wall expansion, the inspiratory and expiratory ratio will be very poor. Okay, now gait parameters. In the observation, we had also discussed about the gait. Okay, here in the examination section, we have to check for each and every events of the gait, each and every parameters of the gait, like the step length, the stride length, the cadence, the step duration, the stride duration, the pelvic tilt. Apart from these all parameters, we have to check for all the events of the gait, like in the stance phase we have heel strike, we have foot flat, we have mid stance, we have heel off and toe off, and in the swing phase we have acceleration, mid swing and deceleration. So we have to check for all these parameters and all these events of the gait. Okay, now for the coordination, we have to check for the coordination through the finger nose finger test, through heel shin test, through tandem walking, or we can also go for the finger to finger test. Okay, now here extremely sorry, this is not coordination, this is tone, muscle tone. Here in the case of Parkinson, the muscle tone is highly affected. Generally rigidity is seen in the patient of the Parkinson. Rigidity means to say that it is hypertonicity, that muscle tone increases. Okay, so we can check for the hypertonicity, we can check for the tone by the slow passive movement. If we perform the slow passive movement of the patient, we will feel some level of resistance during the movement. Now after the tone, we have to go for the staging of the patient. Okay, now this is very important. Staging of the patient is very important to decide the treatment protocol. Through the staging of the patient, we can also check for the severity of the patient. Starting from stage 1, it includes the sign and symptoms is only one side. It means it is unilateral, it is not bilateral. It is whether in the left side or in the right side. After this point, the symptoms will be very mild. The symptoms is inconvenient, but it is not disabling. The symptoms are a little bit inconvenient, but it is not disabling the patient's daily activity. It is not disabling the patient's daily function, daily movement. Okay, now tremor of one limb. Remember in the section of observation we had discussed about the tremor, and in the tremor I told you that we have to check for the intensity of the tremor, we have to check for the location of the tremor and whether the tremor is in all the limbs or it is in any specific limb. So this is why I told you to observe. If the patient is having tremor in one limb, then we can conclude that the patient must be having stage 1. Okay, so stage 1 is the mild condition, and for the mild condition we have to go for any other treatment protocol. Okay, now after stage 1 it is stage 2. From stage 2 it is bilateral involvement. Bilateral involvement is seen in stage 2, 3, 4 and 5. Okay, so here there will be minimal disability and the balance will be normal. The posture will not be affected at such a high level. Okay, now after stage 2 we have stage 3. Again bilateral involvement with mild to moderate disability. From stage 3 the disability will be start to progress more. There will be mild to moderate disability in the stage 3 of the Parkinson, and mild postural imbalance is also present in the stage 3, but the patient manages to lead the independent life. Okay, after stage 3 we have stage 4. Again bilateral involvement, postural instability, and the patient is still able to walk or stand unassisted, but up to a certain limit. Okay, now in stage 5 this is the severe most condition of the Parkinson, whether the patient is totally disabled, the patient is even not able to walk or stand unassisted, the patient is completely restricted to the bed or the wheelchair. So stage 5 is the most severe condition in the Parkinson. Okay, so this was the physiotherapy assessment protocol for the patient of Parkinson. Apart from these all, we have radiological examinations, we have pathological examinations. So these all are other stuffs. Here we have discussed about the physiotherapy assessment for the Parkinson patient. I hope you all understand all these topics, all these stuffs. But still, if you have any doubt in these topics, you can simply DM me on the Instagram at the rate Sedative Physio. Here I have mentioned here at the rate Sedative_Physio on Instagram. The link and the username is also mentioned in the description box, or you can also message me on the WhatsApp. I will help you, of course I will help you, and if you need the slide or the notes, you can simply DM me on the Instagram. And if you want lectures in Hindi language, I have my other channel, you can check it out. The link of that channel is also mentioned in the description box. One last stuff, don't go. There is a link of WhatsApp group inside the description box. You can also join it. We discuss different clinical cases, different questions daily in the group with the references and the discussions. I hope you find this video very helpful. If you liked it, then subscribe to the channel. I will see you guys in the next lecture with the physiotherapy management of the Parkinson. Till then, be happy and keep learning.